trial, which was published, I believe, last year, the Embolden trial. It looked at quetiapine 300 and 600 versus placebo in bipolar type 1 and type 2 depression. And again, we see the same thing that we saw on the other slide, namely that in terms of decreasing your depression score, 300 seems to work quite best, although it's not enormously different from 600. Again, you get a significant response of 300 milligrams per day relative to placebo. And this was an 8-week study. Let's pop over this one. So it's not the case that all of the atypical antipsychotics are associated with improved treatment of depression, even though you can see improvements associated with quetiapine and olanzapine. Another medication, ziprasidone, which has the trade name of Geodon, hasn't really been shown to improve depressive symptoms. And in 2 studies of ziprasidone, the treatment of bipolar depression, they tried a lower dose of 40 to 80 milligrams a day versus a higher dose of 120 to 160. And the primary outcome was the same depression scale that we saw in the previous studies. In neither study did they see any effect on bipolar depression of ziprasidone when used as monotherapy. And these are just the curves for that, showing you that as your depression score decreases over time, ziprasidone in different doses, the red and green versus placebo, in red and yellow versus placebo here in green, don't really separate out at all in any meaningful way. Now, in a recent study that was published by Gary Sachs out of Harvard, that was in the New England Journal of Medicine, suggested that antidepressants weren't effective for treating depression and bipolar disorder. And there's been a fair amount of concern about that because there actually is quite a bit of data that suggests that antidepressants are effective in treating bipolar disorder. So what I was going to do in the next few minutes is go over some of that and then address some of the reasons why the study that was in the New England Journal of Medicine yielded the conclusions that it did. Now, the antidepressants, just to refresh you, we have several different classes. What we call selective serotonin reuptake inhibitors, or SSRIs, which are perhaps the most common, including fluoxetine, sertraline, paroxetine, citalopram, and escitalopram. Wellbutrin, which falls into neither of those 2 categories. Selective norepinephrine reuptake inhibitors, such as duloxetine and venlafaxine, although venlafaxine has some of each activity in it. And then the older medications that are still very effective but have more side effects and are less suitable for bipolar disorder, such as the tricyclic antidepressants, such as nortriptyline, amitriptyline, and azipramine. I won't go through all of this in detail, but the point out of all of these studies, in these controlled trials of an antidepressant medication versus placebo, and these trials were double-blind and randomized and placebo-controlled, if you were to look down here, actually all of these trials showed an advantage for an antidepressant in the treatment of bipolar depression. So just offhand, I believe there's 7 here. Yeah, so you have 7 trials that have all shown the benefit of antidepressants in the treatment of bipolar depression. One thing that people can, so I'll get to that in a second. In a recent meta-analysis of several studies of antidepressants in bipolar disorder, looking at antidepressant versus placebo, the authors, this study was just published about 5 years ago. This study, if you see here, most of the studies favor the antidepressants as opposed to favoring placebo. So that means after the period of the study, which they were at different time ranges, which aren't on here, I don't believe. But regardless of the study, in general, patients on antidepressants showed an improvement in their mood relative to those on placebo. So you have some evidence here that antidepressants actually help depression and bipolar disorder. Now, one of the first studies that did not find any effect here, argued that antidepressants had no greater response than placebo and a combination of lithium. And the initial, if you read that initially, you think that, so if you add an antidepressant to lithium, and you may have heard lithium itself has antidepressant properties, then it's kind of interesting that none of these, the 45, 38, and 34, weren't significantly different in terms of people recovering from depression. But what they found is that patients, if you stratified the patients taking lithium and looked at those with a lithium level of less than 0.8, which would be considered subtherapeutic. Usually a therapeutic lithium level is between about 0.8 and 1 to 1.1. Patients with a lower lithium level who were taking antidepressant actually did do better than placebo. However, patients who had a higher lithium level of over 0.8, or in other words therapeutic, didn't show any benefit. And one of the reasons for this, even though it wasn't as well known in 2001, is probably because lithium itself has some antidepressant properties, and the antidepressants themselves, added to a therapeutic lithium dose, may not have been enough to separate out from placebo. We have a similar issue that we'll come to in the New England Journal of Medicine study that showed that there was no benefit, which is this study by Gary Sachs. And what Gary did in this study, it was part of the STEP systematic treatment enhancement protocol for bipolar disorder, which was a multi-site trial that enrolled about, I should know the number off the top of my head, about 4,300 patients, I think somewhere over 4,000 patients, and followed them for up to 5 years. And incorporated in the trial were some randomized trials of antidepressants. So they selected bupropion and paroxetine or Paxil as the antidepressants because they considered those to be two medications that were commonly used in the treatment of bipolar depression, and two medications that weren't likely to lead to a switch in mood, which I'll talk about in a minute. And they compared those to placebo. Now what they did, however, is they allowed patients to be on a mood stabilizer, which initially meant lithium or valproate. So you start off with a bias with the lithium issues we saw from the previous slide from Charlie Nemiroff's study, where patients who are on a higher dose of lithium don't benefit from antidepressants. But what happened is in doing the study in 2004, they modified the criteria a little bit so that you could, instead of being on, say, just lithium or valproate, you could be on any medication classified as a mood stabilizer. But what that meant is that in 2004, even though the newer antipsychotics such as quetiapine, I think aripiprazole may have been out then, say quetiapine, for example, wasn't approved in terms of, or there wasn't much knowledge of it in terms of its efficacy for bipolar depression. Patients could be on it because it was classified as a mood stabilizer. So what happened is you change the question of, do antidepressants help bipolar depression, to, if you're already on a medication that helps bipolar depression, do antidepressants add much to it? And the article itself wasn't exactly clear, and the New England Journal of Medicine tends to go for what they describe as newsworthy phrases, so they tend to paraphrase things down into a small soundbite that sounds good, which is antidepressants don't work for bipolar disorder. But that's not necessarily the case. Interestingly, as we'll talk about switch rates in a second, I think this is, we can go here. So if switching in this study was less than 10% on either bupropion or placebo. Now switching happens when someone with bipolar disorder is started on a medication, often to be depressed. And in the past, it's more commonly a medication such as a tricyclic antidepressant or TCA. And what happens is, for unclear reasons, that switches the person out of a depressive episode into a manic episode. And that could be, well, the person is happy while they're getting better, but then the consequences, you're just trading one thing off for another, of course. The switch rates, if you're on a tricyclic antidepressant alone, or an MAO inhibitor, monoamine oxidase inhibitor, the switch rates have been estimated to be between 30 to 70%. And so some patients, sorry, I hadn't seen this, how that drops in before. So some patients are worried, you worry about switching. Now, the good news is that in general, the switch rate, if you're not including tricyclic antidepressants, the switch rate is relatively low, usually less than 10%, or 5%, I believe. In this study, this is again the meta-analysis looking at these randomized controlled trials of antidepressants in the treatment of bipolar disorder. In terms of switching here, you can see that versus placebo, the number of events, the triangle kind of gives you, when the triangle stretches more in one direction or another off the center line, it kind of tells you where most of the events are. You can see with the black triangle here, most of the events were on the center line, meaning there wasn't much difference between placebo and antidepressants in terms of the probability of someone switching from a depressive episode to a manic episode. And if you look in a collection of other studies, say in imipramine even, you get twice the switch rate, even though they did performing statistics. This is in the Cone study in '89 of 6.7% versus 3.4%. Nimroff, looking at paroxetine or imipramine in conjunction with lithium, so these patients were already on lithium and getting an antidepressant, you see that about 10% or 7.8% switched on imipramine, and no patient switched on paroxetine. And usually that's what we tend to see in medications. The one that's most commonly cited is bupropion or Wellbutrin as having a low rate or low incidence of switching from depression into mania, but patients can still switch on that as well. So if we look at the probability of switching between mood states between bupropion or Wellbutrin, sertraline, which is also called citalopram, venlafaxine, which is also called Effexor. If you look at the way you read this is the time until a switch along the bottom. That's in days. And what's going up the side is the percent of patients switching. So the higher up you are, the worse off you are. So you want it to be lower. So what you see here is if you go out to 120 days, actually venlafaxine had the lowest probability of switching compared to bupropion, which was much higher. Even so, people still tend to use bupropion a bit more often. It's hard to say in terms of exactly how switching works. There are some other options for treating depression, bipolar depression, outside of medications, as outside of the mood stabilizers that also treat depression and outside of antidepressants. One is using a newer agent, an adjunctive agent. It's usually adjunctive, but pramipexole for acute bipolar depression. And a study a few years ago found that patients in a combination therapy, I believe they were already on an antidepressant, adding pramipexole increased the response rate to 67% to 20%. But the only issue here to bear in mind is that these studies were both very small. And so 60% here is 6 out of 10 people, whereas it's 1 out of 11 for placebo. So these weren't the kind of really large-scale trials that you usually see. Modafinil is also, some people have argued for using that in bipolar depression. Modafinil is, or Provigil has been approved for daytime sleepiness, or to keep people awake in the morning. And there's been some concern that patients may be a bit overly stimulated or engage in a mood switch as a result of it. But there hasn't been too much data that actually supports that fear. And in one study here that was presented a couple of years ago at a conference, I don't know if it's in print yet, by Mark Fry, who used to be here at UCLA, they found that there was a significant improvement in depression scores on patients who were started on modafinil in a double-blind study. And their most common side effect was headache. So the side effect profile is really low. But it's the data aren't very clear in terms of supporting that to be used. Other treatments that there's some evidence of being effective for bipolar disorder or sleep deprivation. Of course, with sleep deprivation and bipolar disorder, nothing is without a risk. And if you have someone who has bipolar disorder and you keep them awake, then you run a significant risk of switching them into a different episode. Light therapy can help too, but again, light therapy also has the possibility of switching people into a different mood episode. The light itself, it needs to be of a certain frequency, so that's why you have to buy a certain light box. You don't have to actually stare into it. It can be next to a computer screen or something like work. And usually people use that, you start about 5 minutes twice a day and go up to about 10 to 15. But if some people think that, well, they really want to get better faster, and most of these boxes have a timer, and the timer goes to 25, and then people think, well, I could start with 5, but it's only a light bulb. And the timer goes to 25, and so they turn to 25. And then you get light therapy-induced hypomania, which is good for a while, but it doesn't really last. So it's good, if one does light therapy, it's good to increase up. Other treatments, there have been some case reports of omega-3 fatty acids, but those, I believe the dose is usually around 2 to 3 grams a day, and it's dependent on the exact. Remember, I think there are 2 components usually in omega-3 fatty acids. There's, I believe it's DHA and DHT and EHA, I can't remember offhand, but there's the 2 types. The balance between them actually makes a difference in terms of whether it might be effective. Folate, there's some evidence of that being effective. And initially people would just try taking folate as an adjunct to an antidepressant. But the problem is that for the most part, oral folate, like in a multivitamin, doesn't cross the blood-brain barrier, so it's not too much benefit to the antidepressant. There's a newer medication on the market. Unfortunately, I don't remember the generic name, but I know the trade name is Deplin, and some people use it in adjunct to an antidepressant. The idea is that it's a different formulation of folate that actually crosses the blood-brain barrier, so therefore it can actually provide some of the building blocks for serotonin and then augment the effect of the antidepressant. I don't know what it costs. Some people I've talked to really like it. I imagine it's not free. And it doesn't really have any side effects. And again, I mentioned before, there's repetitive transcranial magnetic stimulation, which can be effective in people, and is usually pretty side effect free. But as in, say, light therapy, for example, if transcranial magnetic stimulation is done in a medical setting, like Dr. Ian Cook performs it here at UCLA. And it has to be monitored because if the field is too strong, then there's also a slight risk of switching someone from a depressed state into a manic state as well. Some of the studies on that are pretty interesting because they're working on targeting specific regions of the brain with the magnetic waves to increase efficacy. The side effects are pretty mild. They usually encompass some headache or very mild dizziness. The other thing that actually isn't on here but is pretty interesting is Helen Mayberg at Emory has reported cases of doing deep brain stimulation on a specific area in the brain where in patients with intractable depression, I believe